it's me, Dr. Smina Rahman, Gyno Girl. Today I wanted to get online and do a video about systemic hormone replacement therapy and just answer some of the basic questions that often come up. I've done a lot about vaginal estrogen, the safety and efficacy of vaginal estrogen, and this will be one of the videos that I do when I speak about systemic hormone therapy, or menopausal hormone therapy is what we refer to it as. And we're gonna discuss who are candidates, why we treat patients for it, who are not candidates, and what are some of the formulations that I like to use and that are safe and effective. And then we're gonna just briefly touch on the big elephant in the room, which is, does it cause breast cancer or not? Because that is always the fear that patients tend to have. So let's get at it. Remember, I'm Dr. Smina Rahman. I'm a board-certified gynecologist in downtown Chicago with my own practice. I am a specialist in menopause and sexual medicine. So today I'm going to talk about the basics of menopausal hormone therapy, which is essentially what used to be considered hormonal replacement therapy. So now we call it either MHT or HT. So what we're looking at is really the use of estrogen and progesterone if you have an intact uterus, and also testosterone, which we talked about in a different video, this one on testosterone and the use in the postmenopause for hypoactive sexual desire disorder. But what I want to discuss is the North American Menopause Society in 2022. This is a picture of it, came out with another position statement on where we stand with hormones. And a lot of this is through evidence-based research based on one of the biggest research studies that have been done in a randomized controlled fashion for women's health. And it's called the Women's Health Initiative. We'll have to do a separate discussion on this altogether because that is complex in and of itself. But oftentimes I have patients tell me that many times they will discuss hormone therapy with their mom, and their moms were taken off of hormone therapy because of this Women's Health Initiative. And so, it's really important to understand that that study and all the post-hoc analysis and all the discussion around it, has had a tremendous impact on women's health and longevity, particularly for midlife women. When we talk about the number of midlife women, it is estimated that there's going to be 1.2 billion postmenopausal women by the year 2030. And remember, menopause is a retrospective diagnosis. It's 12 months without your menstrual cycle, and basically is when you have your final menstrual period, your ovaries go into retirement, and we end up with a lack of estrogen, progesterone, and 50% less testosterone. I always talk about how there are multiple estrogen receptors throughout our body. And that means that when you lose that estrogen, it can impact menopausal women in many ways. Remember the discussion about women being misled about menopause, where I discussed the article from Sue Dominus. And many of the women, talk about all the different symptoms they've had, from palpitations to, of course, the vasomotor symptoms. That's the hot flashes and the night sweats, this overcoming feeling of heat in your face, sweating through clothes, temperature dysregulation. That's the vasomotor symptoms. And then we have issues around your brain function and cognitive function, brain fog, irritability, anxiety may develop for the first time. Again, midlife women are dealing with a lot. They might be at the pinnacle of their career. They might be taking care of kids. They might be taking care of elderly parents. They might be going through divorces. They might be meeting the love of their life. It's hard to know. There's a lot going on for them. And so when you compound that with losing your hormones, it can wreak havoc on your system. Again, depression, anxiety, all of those, hot flashes, night sweats, not sleeping at night, the 5 to 7 pound weight gain, incontinence, urinary incontinence, low libido, sexual pain, sexual dysfunction, the genitourinary syndrome menopause, which incorporates sexual pain and initial penetration, vulvar vestibular changes, then tissue in the vagina, vaginal dryness. I did a video on the genitourinary syndrome menopause, and of course I talk about vaginal estrogen a lot, but today I'll be focusing on systemic estrogen and the use of hormone therapy systemically. But again, multiple potential complaints here for menopause. This is a meme that I always use in my presentations about the 7 dwarves of menopause, but trying to keep it light. But it's very much a serious situation for a lot of patients and makes their quality of life really impaired. So let's talk about who can and cannot take hormones and where we got this information. Like I said, I'll do a separate discussion on the Women's Health Initiative, but in general, just to recall quickly, it started in the 80s and 90s. Women historically were getting hormone therapy as they entered menopause. Women were living their best lives, they were thriving, were having, longer lives, cardioprotective, less falls, all of this stuff. And so it was over about 160,000 women who were enrolled between the ages of 50 and 79. The average age was 62 and a half. And that is where some of the problems of the study lie, because, the average age of menopause is 51 and a half. So we're talking about women that had entered to this at an older age. When all of the post-hack, and in 2002, July 2nd, 2002, this study stopped abruptly. It was initially a study not about whether or not menopause therapy was effective, but really on strategies for preventing heart disease, breast cancer, colorectal cancer, and osteoporosis, and if menopausal hormone therapy helped that at all. And so that stopped abruptly because of some interpretation of results that led the government and the media and many, many clinicians to buy into the fact that these hormones cause breast cancer, which we absolutely know it does not. I will do a separate video on that. 80% of breast cancer patients have never been on hormones. The majority, estrogen is very demonized by our government and the media. And I'm not here to propose that every patient go on hormonal therapy. I am just here to reiterate the safety and effectiveness of hormone therapy, particularly for certain populations, and talk about the 2022 Menopause Hormonal Therapy Statement by the North American Menopause Society, or NAMS as it's formally known. As we practice and take care of menopause patients, we are really into precision medicine and individualized care, along with shared decision making. I do not practice patriarchal medicine. I will discuss the risk and benefits and whether or not my patients are candidates for hormone therapy, and we will go from there. And if they are interested and on board, great. We try to find the right formulation for them based on their history, their genetics, and their insurance. And if they are not on board with it, we look at other ways to improve the quality of their life. So let's talk about who we should prescribe hormone therapy for. Again, the NAMS position statement, the North American Menopause Society, here's a picture and a link. Basically, when we look at hormone therapy, it is really important to know that it is the most effective form of treatment for menopausal symptoms. And the people that should be considered for hormone therapy are patients who suffer from vasomotor symptoms, hot flashes, night sweats, sleep disturbances from all of that, okay? So that is number one, most effective form of treatment for vasomotor symptoms. The next thing is the genitourinary syndrome of menopause. I discuss it a lot. I talk about vaginal estrogen a lot. It is very safe and effective for almost everybody. So please, 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 do not suffer with dry vagina, do not suffer with painful sex, and do not suffer with recurrent UTIs that can lead to urosepsis and potentially issues with your longevity. The third reason why hormone therapy should be utilized is for patients that have premature ovarian insufficiency or loss of ovarian function in a premature fashion. This can be patients that have had hysterectomies with their ovaries removed. It can be patients so they've had a surgically induced menopause or medically induced menopause for one reason or another. And then the patients that hit menopause before the age of 40 and they have primary ovarian insufficiency, oftentimes seen in women of color, particularly Black women, as well as patients who have autoimmune diseases and other comorbidities can potentially go into menopause at an earlier age and lose their ovarian function. They very much need to be on hormone therapy for their cardiac health, for their brain health, and for their bone health, and for their overall well-being. So those are the categories of people that are listed that should be on, per recommendation, per evidence-based guidelines, per prospective randomized controlled trials. The next thing I want to discuss are people that should not be on hormone therapy. And this is a red full stop. We should not entertain this option. There are nuances to potentially some of these topics, but when we talk about full stop, who we should not, offer hormone therapy, or entertain the option really are patients with active breast cancer, especially estrogen and progesterone positive, patients with a unprovoked deep venous thrombosis or pulmonary embolism. That means that for one reason or another, they developed a pulmonary embolus, which is a clot in the lungs that can lead to premature death, as well as clot in their veins, in their calves, deep thrombosis. They should avoid hormone therapy. The next group of patients would be patients with end-stage liver disease. And that is specifically, we're talking about cirrhosis, we're talking about end-stage liver disease. Some of the other nuances around fatty liver disease and other things is really a risk-benefit discussion that you can have with your menopause-trained clinician. And finally, and then the other topic is around patients that have abnormal postmenopausal bleeding. Postmenopausal bleeding should always be evaluated. There are concerns around postmenopausal bleeding and precancer or cancer of the lining of the uterus, so that's why it should be evaluated. So abnormal uterine bleeding, specifically someone who's had a coronary artery disease, someone who's had a heart attack, a stroke, that kind of thing, we need to avoid hormones in those patients. Another big statement made by the Menopause Society after all of the post-hoc analysis of the Women's Health Initiative and other studies was that the timing mattered. So again, I briefly mentioned the study and how at the average age was 62 and a half, but if you look at the patients that were within 5 years of menopause, they did really well overall. So with this hypothesis, the North American Menopause Society, or the Menopause Society as it's now known, are talking about, again, individualizing the risk, but for women aged 60 or younger, or within 10 years of their final menstrual period, and they have none of the contraindications that I just discussed, the benefit to risk ratio is favorable for the treatment of those really bad vasomotor symptoms and prevention of bone loss and the genital urinary syndrome menopause we talked about as well. So really, we're looking at these patients trying to prevent bone loss. Oh, I didn't actually mention that in who should be given menopausal hormone therapy. The other group are patients that are at risk for osteopenia or bone loss. Osteopenia is defined based on a DEXA scan. Stop, guys, you're too loud. Osteopenia is a weakened bones. It is defined by a DEXA scan, which means you look at your bone density, and if your T-score is between -1.1 and -2.4, I believe that's osteopenia, we need to give those patients hormone therapy to maximize their bone health. And so that is another reason to give a patient these medications. Again, the conclusion arrived that timing matters when you give the hormone therapy and to whom you give it, age related. So within the first 10 years of menopause or less than age 60, again, individualized medicine, precision medicine is what we go for. So we have discussions with patients and reviewing their risk and benefit analysis with them, what their cardiac risks are, what their overall risks are in their health. Remember, breast cancer affects 1 in 8 patients, female patients, and coronary artery disease is still, heart disease is still the #1 killer in patients. So if hormone therapy is found to be cardioprotective and reducing vasomotor symptoms or hot flashes. Remember, the old adage of hot flashes can't kill you is simply not true. We know uncontrolled hot flashes can lead to increase in heart disease, diabetes, sleep disorders, and we know that eventually, this can diminish your life expectancy. So we must treat hot flashes and we must do this to prevent further deterioration of your heart health, so that we can continue to live long lives, but lives of meaning and good quality of life. So those are important. For women who start hormone therapy or who want to start hormone therapy more than 10 years from their last menstrual period or older than the age of 60, the benefit to risk ratio is less favorable. And that is believed because you've already had 10 years or so, without estrogen, the risk of coronary heart disease is already there. You already maybe have developed cholesterol problems, you've developed weight gain, you might have put yourself more at risk for stroke because of blood pressure issues, or you're more at risk for venous thromboembolic disease, those blood clots, as well as dementia. So it's just not favorable overall for women over the age of 60 to start hormone therapy when they've never been on it, or more than 10 years past their last menstrual period. But again, talking about using it for more than 10 years or, persistent vasomotor symptoms, really it's shared decision making. When I start someone on hormone therapy on a year-to-year basis, I'm making sure they're getting their mammograms, they're getting their colonoscopies, they're getting maybe a coronary calcium score to see, what their risk is for, heart disease. I'm making sure their blood pressure is under control, checking their cholesterol, or, having that sent to me from their primary care, so we can every year calculate their cardiac risk score, as well as look at what their other healthcare risks are. So again, longer duration could be documented with shared decision making with the patient. The genital urinary syndrome menopause we've discussed. Obviously you could try the over-the-counter remedies, the hyaluronic acid and moisturizers, but we should be using low-dose vaginal estrogen or DHEA for those patients. So how do I prescribe, hormone therapy when I see a patient? We review all their history, review all their symptoms, and I traditionally will start with a transdermal route. And that is because transdermal, meaning a patch, a gel, so there's, Divigel, there's estrogel, there's the estradiol patch. And we use this and there's also a vaginal ring that is systemic called FemRing. I am not sponsored by any of these products, but I do like them. So I use these products. It's a trial and error for a lot of patients. It depends on what your insurance covers. So it is a lot of meeting and re-meeting to make sure that you are in good condition without any significant side effects. And so with a transdermal, the reason we go for that first and foremost, it does bypass the first pass effect of the liver, which is liver metabolism. So it hopefully will not be increasing your sex hormone binding globulin, which is produced in the liver, which can further lower your libido, like oral estrogen. And it may also does not increase your risk for deep thrombus events, the DVTs and the PEs. So particularly for patients who might have a slightly higher risk, they should absolutely go on transdermal. But that being said, we should, counsel the patient based on what they can afford, what they tolerate, and all of that. And some of it is, you put on the estradiol patch, you use it twice a week. We start on a dose. If you're having some symptoms of, estrogen sensitivity, then we will switch you out to some other method. Maybe you're not absorbing it well enough and your hot flashes and night sweats cannot be controlled through a transdermal route. So hey, then we're gonna start an oral estradiol. Side note, before I talk about these side effects and things, the estradiol that I use in the patch is estradiol, which is a bioidentical form of what your ovaries make, as well as the progesterone I use for patients who have an intact uterus. Again, that is also an oral micronized progesterone, or Prometrium is the trade name, and it is a bioidentical version of what your ovaries make. And when I mean bioidentical, that is a marketing term. It evolved after the Women's Health Initiative, and when 70% of estrogen and progesterone prescriptions dropped because of this pseudo threat of breast cancer, which we know should not have happened, with all of our post-hoc analysis and looking at all of the data now from 20 years. And so we did these patients a disservice. Their longevity diminished, their heart disease increased, the aggressive breast cancers and death from breast cancer increased. We're gonna review all of that with a discussion on the Women's Health Initiative specifically, but it became a marketing term for compounding pharmacies to utilize. And for the use of systemic hormones, we should avoid compounding bioidentical hormones. We should use FDA-approved bioidentical hormones. These are the ones that are studied through pharmaceuticals, and we have plenty of data to suggest that they are very safe in those patient populations I discussed. So the problem with these compounding companies, a lot of them are unregulated. We don't know the exact strength that they're putting in it, is what they say. Some people get super therapeutic levels using implants such as pellets, and other things can cause significant problems. Progesterone in general is not really absorbed well through the skin unless it's a synthetic progesterone like the ones in the patch, the combi patch, the norethindrome, or the synthetic progesterone that's in the IUD, the levonorgestrel in the Mirena IUD. And so those bioidenticals from compounding pharmacies can be very dangerous. I've seen patients develop cancers from those. I've seen patients with micropenises from super physiologic doses of testosterone. And so we need to avoid those, particularly because we do have FDA approved, well-studied products that are amazing for patients and are covered by insurance, not out-of-pocket expense like bioidentical compounded are. So, and then I'm really specifically referring to those systemic medications when we have to use those. So again, I start on the patch. If you don't have a uterus, you're just getting the estrogen patch. If you do have a uterus, you're getting the estradiol patch, the estradiol gel, or the estrogel, or the femring, the ring for systemic estrogen in the vagina, and then you're getting something to protect the lining of your uterus to prevent cancer, because unopposed estrogen will create either precancer or cancer for many patients. And so common side effects of estrogen are really the breast tenderness, nausea, and spotting from bleeding. And so we monitor those symptoms. If you're having too much symptomatology related to estrogen, we reduce your levels, or we switch to a different type of estrogen and a different form of absorption. So that is how I start my patients. The oral micronized progesterone, like I said, is really important because a lot of patients benefit from the relaxing nature of progesterone, the prometrium. Patients do pretty well with it for the most part. It helps them sleep at night, it relaxes them, it reduces anxiety for a lot of patients. But in general, progesterone can cause side effects such as bloating, nausea, and abdominal cramping. We also know that we have to avoid this micronized progesterone, this prometrium, in patients with a peanut allergy. So then we have to use synthetic progesterones for those patients that have an intact uterus and are using estrogen. And what are the synthetic forms of progesterone again? There is norethindrone, which is in some of the patches, combination patches that we have. There is oral forms of it. The oral form of oral micronized progesterone with estradiol is trade name by Uvave, and it is very effective for many of my patients, particularly the ones who cannot get full relief of symptoms from their transdermal route, okay? So I'll start with the patch and the prometrium. If it doesn't work, maybe we'll try a gel, we'll do a daily gel. Some people can't remember to take a patch on a Monday and a Thursday because that's typically how we prescribe it, and so we do daily gels. Sometimes that's easier. There is transference of these gels, so you have to be careful about where you're going to use it, the Divi gel, the estrogel. In case you have an animal or a baby that will lick that area, you may give them a little bit of a dose of estrogen. If a patient cannot tolerate the oral micronized progesterone, we will then try to see whether or not they are candidates for an IUD, which is the levonorgestrel IUD, which has been FDA approved for 8 years. It is a form of contraception, Mirena, but it gives you endometrial protection based on how much progesterone is in there. So that is a potential option to give you that protection. And then we sometimes will use a combination synthetic pill or patches that are out there with synthetic progesterone. Again, synthetic progesterones got a little bit of a bad rap during the Women's Health Initiative because that was what was utilized, and that was the one arm of the Women's Health Initiative that we will discuss that did show a slight increased risk of breast cancer, but no more than what your risk is if you are obese, or what your risk is if you drink 1 glass of wine a night for 5 to 7 glasses a week. So we're gonna get into that maybe in the next video about the Women's Health Initiative. So that's how I start my patients. It's a trial and error, a lot of it, it's a lot of tweaking. Your symptoms aren't totally relieved with this dose, we go up. You're having too many side effects, we go down. Again, individualized care. We share the decision making and try to figure out what is best for you. As after adding the estrogen and or progesterone, we will then talk about the testosterone if you have low libido with concern. And I did a whole video on testosterone as well. And then of course, always addressing the vaginal and the urinary issues, which we've discussed in many other videos. And that's how I started out, guys. There are patients who cannot tolerate any form of progesterone because of the side effects, or one reason or another. Maybe you're a patient with a history of PMD or endometriosis or something like that, and you are very, very uncomfortable with these medications. Then we will switch to a form of a pill called Uvave. It is a conjugated equine estrogen, which is the Premarin that was used in the Women's Health Initiative, and it is a selective estrogen receptor modulator, so it has anti-estrogen effect at your uterus, so protects your lining of the uterus, but it does not have a progesterone in it. So for those patients who have extreme sensitivity to progestins for one reason or another, and perhaps have a history of premenstrual dysphoric disorder or some other medical conditions that preclude them from using any other type of progesterone, then we have an option, which is conjugated equine estrogen. That means it is Premarin, is a different debate for a different time, but that is what is in that medication. And Premarin is from a pregnant mare's urine, and that was a big debate for a long time, but it has been around for decades, and it has been safe and effective, and it has not just the estradiol, which is the most potent form of estrogen that you make in your body, but it also has estrone and E4, which is another type of estrogen, so it's a conjugated form of multiple estrogens, which many patients find very effective, and that is Uvave, D-U-A-V-E-E. So that's it for now, guys. I'm just giving you some basics about menopausal hormone therapy, who can take it, who shouldn't take it, why we give it, and how I prescribe it. And it is a trial and error, and it is precision medicine, and we do have a shared decision making in the process. And I hope that you can find someone that can help you through this. I'm not here saying that every woman needs to be on hormone therapy, but I am saying for those that are high risk for coronary artery disease, heart attacks, diabetes, strokes, we know that there's some cardioprotective effects if you're having those vasomotor symptoms uncontrolled. Like for instance, South Asian women, we make up 25% of the world population, but over 60% of the world heart disease. There's not a South Asian around that probably has not had somebody that they know die in their sleep from a heart attack or drop dead before the age of 50 from a heart attack. And we have a lot of heart disease in our family. So when I see my South Asian patients, will encourage the use of hormone therapy if they are candidates and if they have symptoms. And I will also, encourage them to get those calcium scores, coronary calcium scores as well. But we'll talk more about that in a different episode. So please like and subscribe to my channel. Please give me your comments. I do read them. I might not answer all of them, but I do like to know, what else we need to discuss or what your concerns are. And I'm trying my best to do better. So hopefully you guys learned a little bit of basics about hormone therapy. We'll do a deep dive into the Women's Health Initiative and some data in one of my next episodes. And I wish you well. And if you cannot find someone to help you, please look at www.menopause.org. You can find a certified menopause practitioner, many of them who practice similar to me. Not all of them, I'm sure, but many of them have learned similarly as I have to practice precision, individualized medicine for our patients. Thank you.